Right, it was a lame joke. Just trying to lighten the mood. Anyways, we're back. One of the most common and potentially life-threatening forms of obstructive lung disease is asthma, which affects more than 25 million people in the United States. It typically affects boys more than girls and presents early in childhood. At its core, asthma is a disease of atopy. So look for a history of eczema, allergic rhinitis, and asthma throughout the family tree. And speaking of trees, see that large kid taking his time to make his way down the ladder? Obstructing it, if you will? It looks like we're going to be up here for a while. And that really is the key to understanding obstructive disorders. The problem involves trying to get air out of the lungs, but instead it gets trapped. In emphysema, this was due to alveolar destruction causing airway collapse. In chronic bronchitis, this was due to little mucus plugs clogging those bronchioles. Both of these pathologies are part of chronic obstructive pulmonary disease, a largely irreversible and destructive disorder. Asthma, on the other hand, is characterized by a hyperresponsive airway. It's ready to severely bronchoconstrict, even with the most benign of stimuli. Take this bee here, for example. Really? You're going to wield a 4-foot tree branch against that thing? This kid must have a history with some bad bees. So anyways, as you can see, the airway overreacts. And there are 4 components to this reaction. 1. See that cap he's wearing? It's the official uniform up here in the tree fort. And it's reversed to remind us of episodic, mostly reversible airway obstruction. Chronic bronchial inflammation. Whoa, this guy came prepared. See that fire cape? It's being worn by an eosinophil, by the way. But we'll get to that in a little bit. Numero tres. Don't forget about increased mucus secretion, dripping from our captain's tongue as he prepares to strike. And 4. Bronchial smooth muscle hypertrophy and hyperreactivity, represented by this tight death grip on that weighty tree limb. This whole process takes place in the larger airways, mostly the bronchi and bronchioles. This is why the flame and death grip are centered around the larger divisions of this branch, while those fresh green leaves on the tips, which represent the distal respiratory units, are largely unaffected. Though there are several forms of asthma, the most common by far is atopic asthma, which usually begins in childhood. Hence the plethora of children occupying these treetop dwellings. The classic example of atopic asthma involves an exaggerated Th2 helper T-cell response to an environmental antigen. This squirrel here represents some of those antigens. He blows that little dandelion for dust and pollen. He's covered in animal dander. And here we go. The antigen is picked up by an antigen-presenting cell, then presented to a Th2 helper T-cell, which gets activated. A little too activated. Interleukins 4, 5, and 13 go flying in all directions. 4 and 13 go on to activate B cells, but not just any B cells. These B cells are given specific instructions. Make a ton of IgE. A B cell shooting out antibodies is like an archer shooting arrows. Do you see where she's aiming, though? She's not just shooting arrows willy-nilly. IgE antibodies target mast cells. See how she raises her finger in the air like that? Checking the wind direction before her shot, I'm guessing. But it should also remind you that this whole IgE mast cell mechanism is what characterizes the type 1 hypersensitivity reaction. Mast cells are those granular immune cells that sit out in the tissues, just waiting for the opportunity to degranulate all kinds of pro-inflammatory substances into the surrounding interstitium. Just like this beehive here, ready to degranulate some histamine Bs with even the slightest disturbance. Well, the beehive isn't activated just yet. It's merely coated with IgE. This occurs throughout the large airways, in fact, and these mast cells are primed for reaction next time the antigen is encountered. Shh, here comes another antigen now. When antigen is reintroduced, it binds to the mast cell's IgE antibodies and cross-links them. See how the squirrel latches onto 2 arrows at once? And you know what happens next. Mast cell degranulation. A sudden outburst of pro-inflammatory molecules, including histamine, acetylcholine, and leukotrienes, just like the release of these angry Africanized pro-inflammatory bees. Now, this entire allergic reaction is broken into 2 phases, early and late phase. We're definitely still in the early phase here. To see what all these pro-inflammatory molecules do to your lungs, just follow that bee. Remember that backwards hat kid? This early reaction involves sudden bronchoconstriction. Remember those clenched hands? Increased mucus production. That's why he's all tonguey. And vasodilation, depicted by those floppy, dilated red sleeves. Contrast that with the late phase. See how our inflammatory caped crusader is arriving a little late to the party? 4 to 8 hours after the early phase, the late phase starts. It consists of an invasion of inflammatory cells, including eosinophils, neutrophils, and T cells. On top of that, surrounding epithelial cells are activated to produce chemokines like eotaxin, a potent chemoattractant and activator of eosinophils. So we've emphasized eosinophils in this sketch. Donning the cape is our recurring symbol for eosinophils, that pink and eosinophilically dressed slingshot girl. The slingshot should remind you that eosinophils just love to degranulate their contents into the surroundings, and that's why she's letting those pink granules fly. So now if we step back for a little bit, we can see the two phases of the reaction side by side. That early phase reaction is what's causing your acute symptoms, such as bronchoconstriction, and it's the reason why your patient was rushed to the hospital in the first place. The delayed reaction, however, which involves that infiltration of inflammatory cells, is what's actually causing damage to the airways. Eosinophils, for example, release what's called major basic protein. It's normally an anti-helminthic toxin, helpful if you're trying to combat worms, not helpful when it damages your patient's epithelial cells instead. This is reflected by the sign for the major base, which looks a bit damaged to say the least. Repeated asthma attacks means repeated waves of this late phase reaction. When the respiratory epithelium is exposed to recurrent episodes of inflammation, you're not just doing damage. The bronchial wall actually undergoes permanent structural changes. This is dubbed airway remodeling. Yep, we're always undergoing new construction projects here at the Major Base Treehouse. These structural changes will be embodied by this kid up here, doing some pull-ups and staying fit for the next bee attack. Yeah, that's that inflammatory cape again. It's a little extra reminder that long-time exposure to inflammation is what's causing these structural changes. Let's zoom in on the bronchi first, or this branch here. At the level of the bronchi, you'll see hyperplasia of smooth muscle cells. So imagine this kid's muscular arms getting more and more hypertrophied with each pull-up. You'll also see a thickened basement membrane, represented by this concrete pad holding up the new structure being built. How'd they pull that off? Another sign of airway remodeling is hypertrophy of the submucosal mucus glands, as evidenced by those mucousy water bottles at his side. Gotta stay hydrated. Let's look at the sputum. First of all, remember that eosinophilic infiltration of the airways is one of the hallmarks of atopic asthma. You'll find eosinophils all over the place. If you look at their sputum under the microscope, whoop, there they are. Hence the eosinophilic granules in the sputum puddle here. You'll find them in the blood too, so watch out for eosinophilia on the complete blood count. What about gross pathology? Well, you'll find thick mucus plugs all over the place, including the bronchi and bronchioles. If you look at all this gunk under the microscope, you can see some pretty wacky stuff. Kirschmann spirals, for example, consist of spirally deposits of shed epithelium. It's just like the spiraled string connected to this telephone can, the standard communication network of any reputable tree fort. Notice the can is also filled with a big mucus plug. Under the microscope, you might also see Charcot-Leyden crystals, thin, needle-like concretions made of eosinophil proteins. Just think of these thin, needle-like projections on these jacks sitting in that mucus puddle. You probably won't see your asthma patient this closely on a regular basis, though. So let's zoom out and discuss the clinical presentation of an asthma exacerbation. Because those large airways are so constricted, expect some severe dyspnea with wheezing. Dyspnea is represented by this kid, huffing and puffing at the top of the plank ladder. And diffuse bilateral wheezing is represented, as always, by our diffusely obnoxious wheezy party blower. The wheezing is usually expiratory, but can be inspiratory if the attack is severe. Although wheezing is the symptom we all think of first, cough is frequently the only presenting complaint. In fact, asthma is the most common cause of cough in children older than 3. Look for certain characteristics. A nocturnal cough, for example, should raise suspicion for asthma. Aw, look, he brought a family portrait along. If you inspect it closely, you might just see that other members in his family have a history of either asthma or some other atopic disease. This includes allergic rhinitis, atopic dermatitis, or even a food allergy. A quick word about imaging. Chest x-rays can show signs of air trapping in asthma. And just like we did in our last video, we'll illustrate these on a kite. Asthma is an obstructive lung disease leading to air trapping and hyperinflation. This leads to flattening of the diaphragms from compression, and the cardiac silhouette may seem lengthened, giving the appearance of a vertical heart. Between attacks, though, chest x-ray will be normal. Don't let that trip you up on the exam. Dude, look at that shirt. Pulsus Paradoxus? I love that band. In patients with acute asthma exacerbations, exaggerated negative intrathoracic pressure causes a decrease in left ventricular stroke volume, causing a drop in systolic pressure with inspiration. Last time, it was pericardial fluid putting pressure on the heart. This time, it's those overexpanded lungs. So metal. Wait a minute, all this air trapping? Shouldn't we be able to see this on spirometry? Ah, so you did watch our previous video. Asthma is an obstructive lung disease, so just like in emphysema, you should measure a decreased FEV1, or forced expiratory volume, in 1 second, and your FEV1 to FVC ratio is less than 0.7, or 70%. FVC stands for forced vital capacity. We've illustrated the FEV1 over FVC ratio dangling off the edge there, to remind you that the ratio is decreased in the setting of obstructive lung disorders. Check out our previous video for a more in-depth discussion. A word of caution. In between attacks, just like that x-ray, these measurements might be completely normal. During acute exacerbations, patients will initially present with hyperventilation. That means they're breathing as fast and as hard as they can to get as much oxygen as possible through those collapsing airways. And lots of breathing means blowing off lots of carbon dioxide. So, as she frantically blows off those bubbles, remember that little OH at the end of her bubble wand. This is our recurring symbol for respiratory alkalosis. That might not last for long, though. The classic board scenario involves a patient with an asthma exacerbation that's progressing towards needing intubation. Early on, the patient is hyperventilating and develops a respiratory alkalosis. But when the asthma is so severe that the patient is tiring out and can't keep breathing fast enough, the carbon dioxide builds up and now they have a respiratory acidosis. So take a look at those OH bubbles from before. After a while, pop! You're in respiratory acidosis. All right, let's back up a bit here. As we mentioned before, atopic asthma is your classic allergic type reaction that you'll see in most patients. Remember, too, that these patients often have a history of multiple allergic disorders, including the classic triad of allergies, eczema, and asthma. Then there's non-atopic asthma. This version does not feature this allergic triad, and instead is triggered by respiratory viral infections such as rhinovirus and parainfluenza virus. Hence the viral-shaped lantern lighting up the loft up here, away from the allergens. Inhaled air pollutants such as secondhand smoke and smog are other common triggers. It's thought that some kind of virus-induced inflammation causes the airways to become hyperreactive, and, strangely enough, lots of eosinophils are seen, just like in atopic asthma, and they're treated in a similar way. I also want to briefly mention drug-induced asthma. While there are several drugs that can provoke asthma, we're going to focus on aspirin, the classic example. Remember that aspirin inhibits the COX-1 pathway, so this means that the arachidonic acid metabolites are preferentially processed by the lipoxygenase pathway instead. This leads to an increase in leukotrienes, especially LTC4, LTD4, and LTE4, which cause bronchoconstriction. Patients with aspirin sensitivity classically present with recurrent rhinitis and nasal polyps, urticaria, and asthma. At Sketchy, aspirin is represented by our aspirin umpire, inhibiting the head coach COX-1 and his pro-slugger prostaglandins. Well, in this scene, donning the aspirin umpire uniform is one of the guards of the tree fort. As he raises up that formidable Lox lacrosse stick weapon, keep in mind aspirin's ability to shift the COX to the LOX. All right, to round out the obstructive lung disease chapter, we've got one more condition to discuss: bronchiectasis. Bronchiectasis is characterized by permanent dilation of the bronchi and bronchioles due to infections and inflammation that destroy the muscle and elastic tissue supporting the airway. Just look at these dilated pomegranates found throughout this pulmonary tree here, all rosy and inflamed. Here's the thing: these infections need to be chronic or recurrent in the same region. Either way, the same area of the lung gets attacked by inflammation, over and over and over, until enough damage is done. Let's draw in a few recurring bacterial lanterns, shall we? Our sketchy symbol for recurrent infection. We're missing one ingredient here, though, and that's obstruction. You see, obstruction and infection go hand in hand here. Let me show you what I mean. For example, you may start with airway obstruction from a tumor. The sealed-off airways distal to the obstruction become a perfect incubation medium for bacteria. Say hello to recurrent infection. Or, in the setting of cystic fibrosis, thickened secretions block off airways and predispose the lungs to recurrent infections. It's the most common cause in the US, and it can lead to a widespread, severe bronchiectasis. Those characteristic thickened secretions are represented by thick tree sap in this pulmonary tree. Just think of sappy cystic fibrosis. Did you notice that our crab carving kid had to break up a patch of wavy, ciliated moss before he could start carving? Let these destroyed cilia remind you of primary ciliary dyskinesia, or PCD, yet another cause of bronchiectasis. In PCD, the cilia are missing a dynean arm and just can't beat like normal. The decrease in mucociliary clearance is what predisposes the airway to infection after infection, culminating in bronchiectasis. Alternatively, an infection can cause its own obstruction. In other words, a necrotizing infection can damage the airways, in particular the elastic tissue, and cause airway collapse and obstruction. This, in turn, predisposes that area to more and more infections. In fact, the most common cause of bronchiectasis worldwide is post-infectious. The culprit that initiates the first damage? Mycobacterium tuberculosis. TB is always represented by the recurring TB cactus with superior lobe cavitation. Here, the cavitated upper lobes seen in TB are represented by this lobular tree fungus. Just imagine these overripe pomegranates causing the branches to sag towards the bottom of the tree. On chest X-ray or CT, the lung fields will be crowded with bronchial markings, extending all the way to the edge of the lung periphery. Once again, just think of those crowded, dangling pomegranates hanging all the way down at the tips of the branches. Because of the constant infection and inflammation, patients with bronchiectasis typically have a productive cough. Sputum production is often described as cupfuls. Ugh, careful there. Ugh, what's worse than a rotten pomegranate? Maybe a rotten durian? Anyways, let this girl sampling the fruits and coughing up some rancid fruit sludge remind you of a chronic, productive cough. With extensive airway damage, there can also be hemoptysis. Ooh, that pomegranate looks nice and ripe and red and almost bloody. That fresh red pomegranate blood on her chest is a pretty depiction of hemoptysis, don't you think?
That about does it for the obstructive lung diseases. Up next are the restrictive disorders. Oh, that's so good. Instead of trouble getting air out of the lungs, we're going to have trouble expanding the lungs and getting enough air in.